A couple of things I wanted to mention to you guys today is uh, the things that we've been able to do at the Chickasaw Nation have nothing to do with me. We have incredible leadership here at the Chickasaw Nation. I encourage you, if you're interested, just to read more about the stable leadership that the Chickasaw Nation has had with a governor that we have here in the Chickasaw Nation that is starting his 10th term, his 10th four-year term as the leader of the Chickasaw Nation. And stable tribal leadership allows many amazing things to happen. And that is true for us here in the Chickasaw Nation. While we are very innovative and have done some amazing things, we just a caveat today that we still use a very Fisher Price EHR system. It was a gift to us. The VA gifted the Indian Health Service an electronic health record many years ago, and it is like a DOS electronic health record. And the good news is we did purchase Epic, and we are rolling Epic out in the next year. But a lot of the things that we've had to do in our efforts to protect our patients through suicide prevention programming and crisis management is really without an advanced electronic health record. And so we look forward to what Epic will be able to add to our efforts here at the Chickasaw Nation. And so just wanted to give that caveat. Also, something that I think is really cool to talk about that I won't be talking about today is that we are one of two tribal awardees of the pediatric mental health care access grants, and they have been around, I believe, since 2018. And HRSA just opened that up to tribes in 2021. And so those are kind of known as those Child Psychiatry Access Program grants across the country. And the state of Oklahoma has one, but we actually received one for the tribe as well, where we've been able to focus that just on our tribal territory and the patients we serve here. And it has really been a fruitful project and definitely contributes to some of the things that we've talked about today, but it's taken us into the autism space for the first time, and we've really been able to do a lot of good in early detection and diagnosis for children with autism that are first American served here in the Chickasaw Nation. So the Chickasaw Nation is a federally recognized tribe located in South Central Oklahoma. It is one of the 5 civilized tribes in Oklahoma. Our boundaries include 7,600 square miles. It's really about 13 counties. Our tribal population of the Chickasaw Nation is about 80,000 citizens, and 41,000 of those live in Oklahoma. Here in this map, you can see that bottom section of Oklahoma is really our tribal territory. We are about Ada is where I am at. That's our headquarters. And that's about an hour and a half from Oklahoma City and 2 hours from Tulsa, just to orient you. We are kind of along the I-35 corridor into Texas. So I could also probably do a little bit of education for many hours on what it's like to have a tribal healthcare system, but just kind of to give you guys a short version of what a tribal healthcare system is. We provide healthcare at no cost to the patient for any first American citizen that comes through our doors. We are separate from the Indian Health Service. So if you wanted to understand the basic 3 kinds of clinics that serve Native American people at no cost, they would fall under the acronym ITU. And so I is all of the Indian Health Services sites across the country that are federally run. The T are the tribal healthcare systems, and that's me. We fall in the tribal healthcare system. And the U of the acronym is the urban Indian clinics, which are in urban areas and are funded by IHS somewhat, but largely kind of run like an FQHC. So we as a tribal healthcare system compacted from the federal government to run our own healthcare system. And we sustain ourselves on third-party revenue, much like all of you do, though we have different payment structures with CMS than traditional healthcare systems that allow us a little more reimbursement for Medicare and Medicaid services than a traditional clinic. When I say that we compacted with the federal government to provide our own care, We just said, why don't you take what you allocate to this region for an Indian healthcare facility, let us have that money, and then we will do the rest, and we will build something that is a little more, I guess, bigger and better, if you will. And so that's what we've been doing here since the 90s. We also operate multiple federal grants. We, in our healthcare system, have 4 locations. Our main hospital is in Ada, here where I am, and then we have 3 other satellite clinics in Ada. And we are now on a joint venture journey with the Indian Health Service to build the largest Indian hospital in Oklahoma over the next 10 years, and that will be located on the boundaries of Oklahoma City. That will be a 3 million square foot facility. It just makes me shudder even thinking about it. But we will have an emergency room there and crisis stabilization services. We are a Joint Commission accredited system, so we'll be talking about that a little bit today and how we've maintained compliance and success in all of our Joint Commission site visits, which actually we anticipate one to come within the next 2 months. So you guys know about the anxiety that that brings. In 2014, we were an early adopter of integrated care, and we could talk about integrated care for a long time today. I'm sure many of you know about integrated behavioral health care. For us, at the time, you can imagine the stigma and the lack of utilization of a behavioral health care system in a tribe. It was not working well for us. We had 3 or 4 month wait list. Nobody would go to their appointments. The utilization was just not good at all. So our governor turned our behavioral health provision on its head. We implemented integrated care with a very small team. We started those team members as emergency room embedded, and then began embedding some therapists in primary care and then in the hospital. And then now, quite a few years later, we now have 38 embedded behavioral health clinicians in our healthcare system, 7 case managers, about 8 to 10 psychiatrists, and about 5 psychologists. In our healthcare system, our emergency room, we probably are around 5,000 visits a month. Our dental department sees are probably around 50,000 visits a year. Overall, our healthcare system is probably at 1 million visits a year with 1,000 babies born per year. Our team specifically in integrated behavioral health, which we call medical family therapy, with the changeover to medical family therapy, we now average 15 to 20,000 visits a year. We've proven that mental health care can make money for the tribe, and we're close to $4 million in third-party collections. And we've sustained our telemental health services since the pandemic, and we've had no findings related to suicide care or mental health services in our tribe in all of the Joint Commission surveys over the last 10 years. And we're hoping for another successful one in the next couple of months. So the reason I wanted to mention integrated care is because I don't think that we could do the crisis care management that we do and the quality that we do it, in the ways that we do it, if we did not have integrated care as the primer for our system. So in all the systems we've worked with over the years and consulted with, I don't go in saying you need to do this and this and this for suicide care. I go in saying you have to start with integrated care. And the reason that's so important to me and why I believe it was such a primer is because our emergency room was operating with no consultants available to them for behavioral health crisis. And for those of you that have spoken from the emergency departments, you know how important it is to give emergency departments that help. And while we haven't been able to offer that to them yet at 24/7, we have for the past 10 years been able to give that to them 8 to 5, and it's been a huge difference for us. And so without integrated care, embedded behavioral health team members, I don't believe that we would have been able to prepare our system for the amount of suicide care management transitions that we needed to make and the quality of care that we're providing. So the other thing I could talk to you guys a lot about today is zero suicide, and I'm going to assume that many of you know a lot about zero suicide. If you don't, there's a zero suicide toolkit. You can just Google zero suicide toolkit. Zero suicide truly found us here and changed our lives. And the reason that I say that is, if you could imagine, the weight and responsibility of finding a good suicide care management model for first American citizens that have such a high rate of suicide, that is a weighty task. And so when the zero suicide model found us after our early implementation of integrated care, it just was divine intervention and provided us a roadmap to implement all the things that we needed to implement here to begin saving more lives in our system. And so zero suicide was actually first introduced to us by our state agency, who received a grant to mentor hospitals in the state of Oklahoma to implement zero suicide. And we were the only tribal entity that applied to receive that help. And so they really just brought Chickasaw Nation to us to introduce it to us. And they told us at the time that it would just be an emergency room implementation, that this would be standardized screening and assessment and triage in the emergency department. And as we began initiating zero suicide, it just made sense to us that we could prevent all of those that were showing up in the emergency room by also implementing standardized processes and protocols in our primary care departments, especially pediatrics and adult primary care. So we really needed standardization the most in primary care, because those were the feeders to our emergency department. But also, just to tell you about an emergency department in a tribal healthcare system where people can go to the emergency department at no cost to them. The utilization of the emergency department is high, and oftentimes people don't go to primary care. They just go to the emergency room for everything. And so we have really aimed in our system to get all patients established in primary care to prevent maybe going to the emergency room and the urgent care excessively, or being super high utilizers in those spaces. So our emergency department definitely sees a lot of things because it is free for everybody who goes there. And so for us, we felt like we could focus on ER diversion of psychiatric crisis and pediatric crisis if we could just catch them and their families in primary care. So we have focused on really making sure that all had primary care and pediatrics established so that we would meet them there early and focus on detection early before crisis. So again, we moved to a full system-wide transformation where every clinic, we wanted to be involved in this new standardization of identification and detection of those at risk. That included even our dental clinics, physical therapy, audiology, all clinics, every clinic that we have here, optometry. Everybody was involved in this system-wide transformation, and everybody received the training to screen people early and identify them early so that we can prevent ER diversion system-wide. So our implementation activities that the zero suicide model guided us to was universal screening. We toyed with selective screening for those that were identified to have behavioral health conditions only, but with such a high risk population, we truly believed that universal screening for us was the only way to go. In our pediatric clinics, we average 30 to 35,000 visits a year in pediatrics, and primary care for adults is even more than that. So you can imagine across 4 locations, standardizing all of this process to all look the same. It was very unique because we didn't want one door to be different from another. And so we set out for every site that we have to implement universal screening. You can imagine what it's like asking an eye doctor or a dentist to screen their patients for depression and suicide. It took a lot of stamina to continue on to shake the haters off, if you will. But with good leadership buy-in, we were able to persevere, and we claim victory now. And for each of those that were difficult, once we identified somebody that was suicidal in their clinics or in their dental chair, they understood immediately why we needed that screening. We also got it approved that every single member that works in our healthcare system receives annual suicide awareness training of their choice that we offer. So we create a menu each year, and all of the healthcare workers, from the front desk to the cleaning crew to the emergency room doctors, all of them engage in suicide awareness training. And then something we realized that we didn't know we needed along the way is all of the front desk people that answer the phones or receive people in person throughout our entire system. We have 1,600 employees. They said they don't know what to do when somebody calls on the phone or walks in and says they're suicidal. So we created a full process for helping our front desk staff know what to do with a suicidal person or child on the phone or in front of them. And we embedded that process on a mouse pad at every workstation in our healthcare system. And that really helped people feel comfortable and less overwhelmed in managing those patients that called, because we do have a lot of people either in our state or in our territory or just across the country who may be Chickasaw, who just think they need to call us no matter where they are to help them in a suicidal crisis. So some other things that we did, as the previous speaker mentioned, we weren't prepared, but we, thanks to the Joint Commission, were told we needed a one-to-one observer process. So we needed comforting individuals to sit with all of those that were identified to be at risk of suicide. And this was a huge, huge lift because it requires a lot of manpower and a lot of money to have people just available waiting for our suicidal patients to be identified so that they can sit with them and do 15-minute checks with them. Very big, heavy lift for our healthcare system. What we did find out is the valet service that we use for our healthcare system also has one-to-one sitter training involved in their valet service and their valet company. They actually do transporting and one-to-one sitting and valet parking. So we were able to use that contract to utilize those individuals that are here, and they're kind of trained in all of those things. And so we just increased that contract and we utilize that service here in our system for one-to-one sitters. The other things that Zero Suicide brought us was just standardized treatment and follow-up. Whenever I, as a behavioral health leader, looked at the way that we were managing suicidal patients across all the different disciplines of behavioral health providers, across all the clinics, across the hospital, the outpatient, everybody literally was doing something different. And everybody just kind of made up their own system without really knowing what evidence-based tools to utilize. And so standardizing across every location, but every discipline, surgery, specialty clinic, hospital, the dental clinics, primary care for peds, primary care for adults, getting everybody to use the same assessments, the same process, the same interventions was what we spent our first several years working on. So additionally, I told you that we have 38 behavioral health providers in the healthcare system. That's a mix of disciplines for behavioral health providers. And so we actually needed all of those 38 to be practicing the same way as well for standardization. And we've actually found that that's what Joint Commission looks at, is everybody across all sites assessing and identifying patients at risk and triaging them and responding to their screeners in the same way. So we created a standardized treatment follow-up plan for our patients after they're identified. We ensure that they have a safety plan. We have a partnership with a state on-call service who tracks our patients. They follow up with them when needed, and then we also follow up with our patients within 72 hours, inspired by the Joint Commission Sentinel event alert that it still is a risk event. That's very common, that people die within 72 hours of leaving a hospital facility of suicide. We follow and track attendance of all of our patients that are at high risk of suicide in something I'll share with you a little bit. And then we make sure in their medical record, even though it's a Fisher-Price version, that everybody knows this patient is at risk of suicide. So one thing that I wanted to talk about that was a big change for us is that we used to treat all suicidal patients the same. So if a patient was identified as at risk of suicide, they were just called suicidal. They weren't called low, moderate, or high risk of suicide, where there was a different level of intervention based on the stratification of risk. So it was extremely transformative of our system to create, through use of the Columbia screener, the identification of people at low, moderate, or high risk, because that allowed us to only send people to inpatient treatment that had to go who were at the highest risk of suicide. But we stopped sending all the people that were low risk of suicide to treatment. And as I told you, we're rural and we don't have any treatment facilities here where we live. And so our law enforcement, our tribal law enforcement was having to transport people at least 60 to 120 miles each way to take a patient to an inpatient facility. So as part of our ER diversion, by stratifying people at low, moderate, or high risk of suicide, we dramatically decreased the number of transports of patients that we were sending to inpatient treatment or that we were having board in our emergency room, because we now had these standardized treatment and follow-up protocols for tracking our patients. And when I said earlier that we had 7 case managers that we added, we used to operate with no case managers, and we actually converted some of our available therapist openings to add more case managers or care coordinators or navigators, whatever you want to call them, because we realized how much work our therapists were doing tracking all of their suicidal patients. So when we converted those therapist positions to case manager positions, the weight that it took off the therapist was amazing, but we actually created just a really great care coordination system for tracking our patients at risk for suicide. So one of our greatest successes here is creating a suicide care pathway, and it may be a little bit different than what you guys know as a suicide care pathway. If you have the cool EHRs, remember, we're not in the cool kids yet with a cool EHR. So our suicide care pathway is literally just an Excel document that we keep in a really, really secure place. We call that the suicide care pathway, and it's managed by those suicide prevention specialists, care navigators, care coordinators, as an assist to the therapist. So we believe that this suicide care pathway is the thing that fills in the holes in the Swiss cheese for us. It tracks literally day to day every patient that's at risk for suicide for maybe 30, 60, 90 days. So a lot of our models at our hospitals or emergency rooms are really just treat and street the suicidal patient, stabilize them for the day. And then beyond that, we hope that they do okay. But we've really changed our mentality that patients are at risk for suicide for an episode of care, not just the day that they present to us as suicidal. So we've really adopted our suicide care pathway to track people longitudinally through their full episode of risk until they're no longer at risk. So this suicide care pathway is staffed weekly in a huddle of our behavioral health care teams and our front desk staff, so everybody knows who the patients are at risk at each location and how badly we want to make sure that we don't lose them in the cracks. So I just copied a few examples of the headers of the things in our Excel document for you here. A lot of people emailing me and ask me for this, so I just encourage you to take a screenshot if you're interested in it. This is literally what our care coordinators use every day. They enter our patient, the date that they were in crisis, what their Columbia level of risk was. Did they get a safety plan? Did they get a referral to our partner that can follow up with them? Did they have to be admitted to our hospital for medical stabilization? Were they voluntarily or involuntarily admitted to an external facility? What time of day did they come? We also have that. Are they a substance use user? Then in our notes, we track when we call them and when we get a hold of them. Did we send them a handwritten note? So you can see that for a patient that we're tracking this on, we are determined not to lose track of them or to communicate in any way that we don't care. And Tona and Trevor, I'm not looking at the chat, so if I need to stop, just let me know. Thank you. So our greatest success right now that I truly am so proud of is that just on my team alone, we have tracked 3,500 patients in this Excel sheet, which is so Fisher-Price, I know, but we have not lost one of those 3,500 patients to suicide. And we just feel so proud of that and so grateful for that. And so our Epic builders we're really hoping can build this for us in Epic, and we can, impanel and still follow all of our suicidal patients in the same way using something like this because we feel it really has been successful for us, and it really is just an Excel sheet. But with a high-risk population, we believe that our kids and adults deserve this level of tracking to make sure that they stay safe. When I last ran the numbers of the 3,500 on our care pathway, we were at about 900 of those were children. So that ranged anywhere from the numbers that I ran from 7 to 17, essentially. 7 was our youngest. So right now we have all adults and kids in one pathway, but we received a grant that allows a focus on youth. So we're thinking that we're going to pull the kids out of this mixed pathway and have the kids in their own pathway, where that youth team will just manage the kids only in a separate care pathway. So some of our successes so far is just that we've screened hundreds of thousands of patients. And as I mentioned, the biggest thing is that we now match the level of intervention with the level of risk. And there are a lot of resources for that. I just Googled before today, looking at primary care zero suicide implementation, or ER suicide, zero suicide implementation. And you can see by multiple authors how they have created a pathway where the screener identifies somebody as low, moderate, or high risk, and then that determines the level of intervention. So we have learned that not everybody needs to go to inpatient treatment, and actually when they go to inpatient treatment, they sometimes get worse. We tend to lose track of them more often. They get off their medications. So it actually cringes me more now to send people to inpatient than to not, because we actually like keeping our patients in our system, in our community, with our staff, with their families supporting them, rather than sending them that 60 to 90 miles away, where they're in another system that's a non-tribal system. We do have great partnerships with the facilities that we send our patients, and we make it very clear to them that we want our patient back. So when they do discharge planning, they actually have a form that we created that goes with the patient that tells them who the team to contact is when the patient discharges. So we have a psychiatrist identified, we have a therapist identified, we can have an appointment identified. But we don't want these people to just be discharged to the streets or discharged to a non-tribal entity to serve them post-discharge. We want them all back in our care. And so we try to establish that very clearly with all the entities that we work with. We feel like we've been really successful in ER diversion. I've talked with some of you before about the ER boarding for children and adults. We really don't have that problem here. And I know some of you may want to throw tomatoes at me for that, but in the past 6 to 9 months, we've only had one child that had to be in the acute care for like 3 or 4 days waiting for a bed. We didn't board them in the emergency room. But again, I really think that because we have such a robust team to manage people during their risk period, post ER visit, we really don't send a lot of people inpatient as much as we used to. And our emergency room physicians have a lot of confidence in our team. They know that we're going to follow up, and they know about the suicide care pathway. They know we're not going to lose track of their patient. So where they used to tell us every patient's going inpatient, they now let us decide with them in conjunction as an integrated team, which is really great. At the Chickasaw Nation, we have our own tribal law enforcement. They're called the Light Horse. And the Light Horse would be the team that has to transport all of our patients. And so we did a cost analysis on a patient that would stay in the emergency room, have to be transported by law enforcement to and from the facility, and what we would save if we didn't do that. And it was like $5,000 to $8,000 per patient. So the law enforcement is really grateful that we have a standardized process for managing our suicidal patients, because they don't have to travel as much. Additionally, our state contracted with third-party transporters that are non-law enforcement police officers. They're like retired military or retired police officers, and they transport our patients without being in handcuffs, which is great. And so we have made our own contract with the state vendor for those third-party transports. And that has also been a huge help to our law enforcement, not having to transport all of our patients, because our law enforcement here has gotten a lot more assigned to them lately. So they're really grateful too to have that help. The Heartline is something that our state has that a lot of people tend to ask me a lot of questions about as a follow-up. The Heartline is, I would say it's kind of like it's a call center, if you will. It was there before 988 was implemented, but the Heartline is a contracted partner with us that the state pays the tribes contract with. And with a patient's consent, we make a referral to the Heartline, and the Heartline calls our patients as long as they need to until the patient is outside their window of risk. So if you remember, I said that we only have our therapist available 8 to 5, Monday through Friday. Nights and weekends and holidays, the Heartline assists us to track our suicidal patients, and then they give us a weekly report about how those patients are doing. So in that huddle that I mentioned where we talk about the suicide care pathway and what patients are at risk, we include the report from the Heartline in that huddle to have that extra set of eyes on our patients to know how they're doing. As I mentioned, through our implementation of Zero Suicide, we've identified people at risk in every department that we have. The eye clinic, the dental chairs, the physical therapy clinic, our WIC offices. We detect people everywhere, and we find them, but we're grateful that we do find them because it's early, and it's finding them not in the emergency room, which was what our aim was. Obviously, we still have them in the emergency room, but identifying people early in primary care and pediatrics allows us to provide intervention early on to prevent our patients from getting to the highest level of crisis that might require boarding or inpatient admissions. And so we really are looking at early intervention and prevention through our screeners and assessments. As I mentioned, we've been asked by the Joint Commission to submit as kind of a gold star, gold standard program. They really love all that we've done here. And I recently listed out everything in every category that the Joint Commission needs that we do in our system to be standardized for suicide care management. So I'm happy to share that if anybody ever wanted to email me for that. Again, the Joint Commission really seems to be focused on environmental things, screening and doing something about your screenings, and making sure that we have that standardized assessment process throughout our system. The Joint Commission has actually been wonderful in supporting Zero Suicide, and they've actually published numerous things that they actually encourage the adoption of Zero Suicide. So when we found Zero Suicide, we then found a publication by Joint Commission that recommended Zero Suicide, and it was just like, great, great that this Zero Suicide model that we're pursuing also is Joint Commission promoted, was just so great. And some of the documents that I've seen that the Joint Commission has produced actually seems like they had the Zero Suicide model and elements of Zero Suicide right next to them as they wrote their protocol. And so their document, that is the R3 document on suicide prevention and suicide risk in healthcare, very, very much mirrors the Zero Suicide model. And again, the thing that allows me to sleep at night the best is just that we have standardized practices, documentation, and protocols in every location in our healthcare system. And overseeing such a large team of behavioral health providers, I just needed to go to sleep at night knowing that everybody was doing it the same way. And we now have that, and no matter whose chart we pull, no matter what provider, we see the same processes and the same screeners, documentation, follow-up plan used in all of their charts, which is really great. So just a couple of grants that I want to tell you that we use to support this work. We have a SAMHSA grant called Native Connections. It's that youth focused grant for ages 11 to 24 that we originally wanted to use to hire therapists. But remember, we changed our mentality that we actually need bachelor's level case managers more than anything right now to manage that suicide care pathway and just do all the things that require tracking our patients. So we hired 2 from that project. And then we have an Indian Health Service grant that we hired another 2. So that's kind of our suicide care team right now that manages that suicide care pathway. We have both of those for 5 years, but we believe that we are proving sustainability of those positions, not only by the number of lives that we have not lost, but by the amount of increased billable services that our clinicians are able to do by having those care coordinators and suicide prevention specialists manage all their patients. We've been doing a lot of 988 implementation and advocacy. I believe in Washington, they are the model for kind of having a tribal option when you call 988. When Oklahoma implemented 988, we didn't have that luxury. And so when I asked our vendor kind of, how would they get somebody who's Chickasaw or First American that lives in our territory, how would they get them to us after they've called 988? They weren't able to tell me what that pathway would really be. They just said, we will Google what services, tribal services are available for the patients in the area, and we'll get them to you that way. And because we're such a big system with a lot of doors to enter anywhere, I just asked them, would you mind if we gave you a process for getting our tribal citizens to us so that then if you talk to them and they're stabilized, you can then hand them off to us in a warm handoff fashion where we go person to person? And they said, sure. So we were the first tribe here in Oklahoma to create this workflow where we gave it to the 988 staff to get our tribal patients connected back with us after they've had a 988 experience or call there for both youth and adults, both texting and on the phone. So we're really, really grateful that they allowed us that partnership to make sure that First American citizens are connected back with their tribe. So this is just my email or my director's email if you would like to contact us or have any questions about what we've provided today. I don't know maybe where this sits with all of you and if any of this is helpful, but I really hope so. Truly, our lives here have been changed because of integrated care and zero suicide. And we are fortunate to be able to help a lot of tribes in our area in these ways. But again, thank you for the opportunity to be here today and to talk about this. And I don't know if we have time for questions or what happens next.
We do have time for questions. And let me just say, blown away again. Thank you. Thank you for sharing. There is a question in the chat, and maybe this is answered by the whatever you put together for the Joint Commissions. But the question is, do you have a toolkit that can be shared for the rollout of universal screening across a discipline? So, how did you work this with the dentists and the opticians and all? Do you have that? Yeah. Okay.
Yeah, I don't know if I would say, I'm probably not fancy enough to have a toolkit, but zero suicide kind of was the model for us, I guess, with that, because the first stop it encourages you to have is leadership buy-in. And I've seen a lot of systems that when you say getting leadership buy-in, people think that might just be like the chiefs. But I believe true system transformation has to come from literally like the C-suite and CEOs. And so for us, once we had leadership adoption and encouragement that everybody was going to implement this screening, even if they were grumbling, the leadership implementation of an advocacy saying this is what we're doing is really what helped us. And the other thing I would say, if I made a toolkit, when I saw with the hospital at some point, we have an acute care and an OB. They had at some point implemented like this 20-question depression screener. It was called Sad Persons. It was super complicated. And when we talked to them about universal screening, we just said, we need you to just ask these 4 questions. Um, and they were just actually relieved to have less questions. So some people didn't want to have more. Some people were great, and grateful to have less. But all of that started with leadership buy-in, I say would be the first thing in my toolkit.
That's awesome. I'm hoping we can get a copy of what you gave to the Joint Commission. So we'll
Yes.
put that in our.
Yes. Yes, I can send you that.
That'd be great. We have 2 people lined up for questions, but I'm going to ask one quick question that I already know the answer to because I asked it before, but I want people to hear this. And my question when we met before was, how are you maintaining your mental health staff when there's such a tremendous turnover, at least here in Washington State, in community mental health centers? And then I'll shut up and I'll move to the next questions.
Yes. So I don't know how it is in other states. In Oklahoma, after COVID, our salaries across the state for behavioral health staff exploded. And just for a point of reference, when I started seeing patients as a therapist in 2005, my salary was $35,000 or 32, I think. And now here in Oklahoma, it seemed like overnight, maybe it's from ARPA funding, I'm not sure. It seemed like overnight behavioral health providers in Oklahoma could make $80 to $85 to $90,000. And we at the tribe were paying like $55,000 or $60,000. And we had a very, very big crisis on our hands because all of our therapists were getting all of these marketing tools about all this money they could make and stay at home and, all of this stuff. And so they were burnt out. They could leave for more money. They could work from home, all those things. So what we did at the time is begged and begged and begged for a market analysis of our therapists to raise everybody's salaries and the managers that oversee them. We got that done, and then we got approval to offer flex scheduling, 410s for patients, or remote work for some as well. And so we really here, besides all the amazing benefits at the Chickasaw Nation, we have great health and bonus benefits here. We had to do some emergency salary raising, and emergency offers of flexibility to our therapist to allow them to be here. We are fortunate in that a lot of our therapists, they literally love what they do working on site. And so they didn't want to work at home. Our ER therapists don't want to leave their ER team. And I think because of integrated care, our therapists are truly bonded to their healthcare teams. And that really helps in times of burnout because they're all in it together and they're all coping together. But some of them, when we were like, you need to maybe start working at home a little bit, have a break, they're like, I'm not leaving my team. And so for us, increasing salaries, adding some flexibility, incorporating a little bit of fun, we really have had minimal turnover, and we're finally fully staffed from our vacancies as well.
Thank you so much. Okay, I think Chip first and then Monty.
Thanks, Chip Schreiber, Rapid Mental Health and Harbor UCLA Pediatrics and the UCLA National Center for Child Traumatic Stress. I guess I'm interested, well, in so many things. It's such a comprehensive approach to a complex problem. I'll just highlight a couple. One is, I know you talked about 988, but in some areas they're talking about youth-focused 988 mobile response teams. Do you have, or what's your view on mobile response teams? Does integrated care really reduce the need for that? So that's no longer relevant? And then also I'm wondering about linkage to schools. And I think you touched on primary care pretty well, but the linkage between primary care and schools in the pathway, in the care model. Really curious, your thoughts on that. Thank you. And thanks for coming back and spending more time with RAPA.
Yes, thank you. And the presentations today have been wonderful, by the way. I guess, so we don't have mobile crisis teams in the tribe, and I guess I'm really protective of my patients because I don't really like the state's mobile crisis teams responding to our patients either. And it's just based on patient feedback that it's not a good experience when that has happened. And so we really, really prefer that when patients are in crisis, they just get to our emergency room. And that opens them up to being in our care pathway. But we do have mobile crisis teams that are launched from 988. And because we don't have our own urgent recovery centers, when a mobile crisis team does respond to somebody from 988, they do go into a state facility that is an urgent recovery center, if the mobile crisis team that responds deems that necessary. For us, the state that has the mobile crisis teams, we have a partnership with them. And so again, I don't know if this answers your question, Chip, but and we really don't hear of them responding a ton for our tribal citizens, but if they do respond to a tribal citizen that they know is served by us, we almost immediately know that that patient has been responded to with that mobile crisis team, or that that patient is inpatient at that facility in our area, so that we then take over and plan discharge with them. The people that we don't hear about and they plan discharge with, it doesn't go well. And so we really try to meet with the urgent recovery centers, which the mobile crisis teams take people to the urgent recovery centers, so that we always have a pathway back to us. We would like maybe our own mobile response teams, but again, pretty much families know just to get them to our ER, and that's really all that we can do right now. The same with schools. So when you're working with tribal healthcare systems, and we are the tribal healthcare system for our 13 counties, when a school has a Native patient in crisis and they're not really sure what to do, we are their first call anyway, because the family wants to be served by the Native healthcare system anyway, and it's no cost, and they need to use some of our payment structures in the tribe to help get the patient help. So I know of numerous situations where a patient has told a school counselor they're suicidal, and we always end up seeing that patient the same day, or they get them to us, so that we can work with the family. So I don't know if that's just by nature of us being the only tribal system here, but if there's any Native American child in crisis, we're always the first contact anyway. And we want to be that. So we don't ask the school to send the child to the emergency room. We say, please don't, actually. We just ask them to bring the child to us in our behavioral health clinic, not to the emergency room, and we handle things from there. So the schools don't have anybody else to call to help a tribal child except us. So I think that that's good. But as far as intervention in schools, we don't have anybody embedded in schools right now that are clinicians or anything like that.
Thank you. Monty, you've been waiting patiently. Thank you for doing that.
Yes.
Hey, Monty.
Hey, Bozu, how you doing down there? Good to see you, Annette. Well, I guess we're the only two tribes of the 580 who are on this call, looks like. So
yeah.
But my question is, I really appreciate what you were saying in your presentation. But my question is, I always ask you are, oops, sorry, get out here. You are one example, but we know one thing I did not hear in your presentation, Shannon, was the cultural competency piece. I know for the Mille Lacs Band, who I work for, we really try hard, because the one thing our tribal members hate to say this, is going to a white person who's a therapist in our tribal clinics. Because they have no idea about the genocide created by the U.S. government from first contact, from first contact, treaties, assimilation, relocation, and termination, and the 7 generations of trauma. And the big thing we're focusing on is blood memory. And especially when you look at the relocation in 1950s, and they're sent to Los Angeles and Minneapolis and, Seattle, that blood memory goes with them. And the one thing that, I hear is the fact that traditionally most tribal nations do not have therapists or intervention teams that look like them or look like me. Even myself, my EMDR, because I've been 35 years as a tribal EMT, is a non-native person.
Yes.
And it's hard because I have to explain the 101 about, about all my traumas that are running through my DNA as an Indigenous man, not only through my career in tribal public safety for 35 years, but also now as a Native father of a missing and murdered Indigenous daughter of 2 years ago who was murdered. So to go to a Native therapist, I don't have to do that. And realizing what you didn't talk about also is your tribal EMS in Chickasaw, because a lot of times we are the first point of contact, and we're the ones who transport our kids to those facilities, because unfortunately tribal law enforcement is so stretched so thin and across the 580 tribes that they don't have the ability to transport with that one. And being the only Native responder in my department, a lot of times I'm the one doing the crisis intervention because they're all my relatives, so
Yes,
that's
and I
also
think
trauma I sustained also, because when you see your own relatives in trauma and they want to see you because you're family, that's also a unique gift that as Ojibwe people our teachings tell us about, and that's the part a lot of people on this don't understand. When there's 580 federally recognized tribes, and that's 580 different traumas that are out there in the community. And there's 580 traumas that are going to urban areas because of relocation back in the 50s.
yes.
And it's and a lot of times we see our young people do not understand, especially with their kids, that their reactions is that blood memory, that they never knew that grandma and grandpa were forcibly gone to boarding school and were sexually molested and beat by the nuns and the priests and never talked about it. And now they're displaying these behaviors and don't understand where it's coming from. And you have non-Native therapists who want to go to the DSM-5. And I'm sorry, he said, you can't go there. You have to speak to the elders and understand the trauma that sovereign nation of the 580 experienced. And that's your diagnosis more than the DSM-5 book can tell you.
Yeah, and I think I remember, Monty, last time you talking about that trauma that you as a first responder have. And our first responders don't run call like traditional first responders.
Yeah.
They serve as a transporter. But
Yeah.
I think the cool thing about the Chickasaw Nation is how much we prioritize Native hiring. And I would say 70% of my team is Native.
Yeah.
But maybe only 30% phenotypically look Native. And so
Yeah.
most all of our patients, all of our suicide prevention coordinators are Native.
It's good.
They, and I think that, people may not know they're served by Native because they may look like me,
Right. Yep. Yep.
And so I think that we have done a really good job at considering levels of acculturation depending on who we see.
Yep.
And being kind of a non-reservation based tribe, we really see a wide range of traditional natives to Chickasaws that have never had anything to do with their culture and maybe don't want to.
Yeah.
And so it's really hard to have one model when you serve. We probably serve 40 different tribes here. And we do a lot of education on Chickasaw culture, but that doesn't really fit for other tribes that we serve. And as an Indian healthcare facility, when you're serving 30, 40, 50 tribes, really the people that teach us is our patients. And we really, really attune to our patients. And in our trauma work and EMDR work, we have a former boarding school here. We have great conversations with our patients that teach us for them where they are at their level of enculturation to their culture, where they are at and their level of trauma awareness from their own past. But if you've seen Killers of the Flower Moon, we've been talking about this a lot lately.
Yep. I saw that up here. And in fact, the Mille Lacs Band, we own our own tribal theater, so we watched it and we all got free admittance to it. And all of us who went to it were devastated to watch just the genocide towards Indigenous women. I mean, this scene, and it was all about the money. And people forget that genocide happened by the federal government for land, for resources. And we were seen as Vernon, basically, and that movie showed it so well. Or 1923 with the boarding school scenes in 1923. And I could barely watch it because that's when my grandmother survived was that much physical and sexual abuse by the nuns.
Yeah, and when we talk about adverse childhood events, and I'm sure you've seen what's on that list.
Oh yeah.
For tribal people, what's on adverse childhood events, it's not even on the list, right?
No,
And so
no.
we don't really adopt. I mean, we all understand the ACEs model, but as far as the ACEs assessment for tribal people, while some of those ACEs may be relevant, the historical trauma or things that their families have been through don't even, they're not on that
Exactly.
scale. But
No.
thank you for the conversation. So important.
And if you can, Shannon, could you email me your slides, please? I want to forward that to our tribal behavioral health, because I think, especially with the front desk people, because they truly freak out here at our tribal health facilities, that they get somebody in there who doesn't understand, and they're just tribal community members, and now they're sitting there and don't know what to do with that. Yeah, so if you can send me that, that would be great.
I put my email in the chat,
Okay.
Bonnie, if that's helpful to you.
Yep,
Good to
I will.
see you again. Good to see you.
Yep, good to see you. And keep in touch, because like I say, we all need to share each other, because there's 580 federally recognized and large urban areas, and we need to keep sharing information, because behavioral health is the root of all the historical trauma that we live every single day.
Yes, and when any of our citizens go to non-tribal systems in the state, I just wish they were a little more culturally informed as well.
Oh, we could go on for 3 hours about that one, believe me.
Yes.
Thank you.
Good to see you.
Yeah.
For the question, and thank you, Shannon, for the answer. The conversation was excellent and really informative too. Appreciate that.
Thank you guys for all the messages.
Oh gosh, yeah. The chat is full of, holy cow, this is wonderful. I don't think I saw any other additional questions, so we're going to let you go and move on. Thank you again very much.
Thank you guys.